welcome to the Dissociative Table podcast. My name is Alex Farchis. Today will be the first in a series of episodes featuring Dr. Phil Manfield, trauma therapy legend, EMDR innovator, and creator of the Flash technique. In this segment, he'll be discussing the use of Flash in Ukraine and forthcoming research from that, as well as the neurobiological underpinnings of trauma reprocessing in general. Also, he discusses the possibilities for integration of Flash with any method, in particular with prolonged exposure to reduce dropout rates, for instance, with the veteran population. He also touches on his own personal journey to trauma therapy through his own experience with a car accident. I believe, most importantly to the nature of this podcast, there's a conversation regarding the quest for the orienting response and the conceptualization of complex trauma as the result of neglect, active or passive, and the role of attention and narrative in healing. He touches on some FMRI studies as well that shed light on the conceptualization of trauma as a set of phobias, which is a particular interest of mine. Enjoy. Dr. Manfield, welcome to the Dissociative Table. Thank you for coming on. You've been a big part of the growth of my own career, as well as that of many of my colleagues. So thank you very much.
My pleasure.
So if I could introduce you to my audience here. For all of you that don't already know, Dr. Manfield is an internationally recognized authority in the treatment of trauma with EMDR, and is also the originator of the increasingly research-validated and revolutionary Flash technique. Flash is gaining such popularity that it had its first international conference and is being used in Europe to treat refugees from the war in Ukraine. He's authored or edited 5 books about psychotherapy and the use of EMDR. He's an internationally approved, EMDRIA-approved EMDR trainer and is taught in the US, Canada, South America, Europe, Asia, Australia, and the Middle East, and he's currently Northern California Regional Coordinator for the International EMDR Association.
Yeah, I think actually, to be more accurate, the International Association did away with regional coordinators, so I'm not anymore.
Oh, okay. All right. Well, I don't know if that's a good thing or a bad thing.
Oh, it's mixed.
Yeah, there's some political stuff going on. I hate that. Well, all right. So this is a podcast about complex trauma, and Flash is the first thing after learning EMDR that allowed me to have success in treating complex trauma with EMDR. And I remember that the comment that was made on the first training that I attended by Dr. Engel was EMDR revolutionized the way that I did therapy, and Flash revolutionized the way I did EMDR.
Right.
But now Flash has taken on a life of its own.
This is true.
And so I'll just start with some questions. Could you speak a little bit about the use of Flash with refugees from Ukraine? We hear about the atrocities committed on civilians, and this is trauma at its worst.
Yeah. I wish I could report more. We've trained, we got a request from a therapist in Ukraine who did a lot of trainings herself and was very well connected for us to provide training to Ukrainian therapists to do Flash. And so we set that up and we did a training with about 300. And then about 3 weeks, 4 weeks later, the Ministry of the Interior in Ukraine wanted training for their therapists. They have a bunch of therapists that are just work for that ministry. And so we trained another 300.
Wow.
So we've trained 600 in Ukraine, but unfortunately, we don't have a lot of follow-up information. So I can't say, all these Ukrainian people have been helped. I hope so, but I can't. Hasn't been really documented. We did some follow-ups where we did consultation for Ukrainian therapists, and that seemed to go very well. But again, it's we're really dedicated to doing research, but it's hard to do research when that might take something away from what we're making available to the people who need it. So we're always looking for opportunities to do research where people will still get the same benefit from the treatment.
Right. It's difficult to do controlled research in such an uncontrolled situation. And
exactly.
That was the criticism of Dr. Shapiro's first study with Vietnam veterans, right? They thought, well, this is unethical. This is effective. It's unethical to deny treatment to the control group. And so we know where that went to. So I'm sure there will be some research coming.
Well, there is research happening, and I understand there's some people, researchers from Turkey that have launched some research in Ukraine, but everything takes time.
Yeah.
So the other thing is that there's a guy who is a trainer for the humanitarian EMDR, humanitarian assistance program, who has a Polish heritage and has now gone, I think, 3 times to Poland, and has worked with Ukrainian refugees through an interpreter. And so I have gotten that feedback. The nice thing is that he goes into these situations with refugees, and he does the treatment. Then he gets to see them the next day, and it's very touching to hear his description of how they just seem like different people the next day.
Yeah. Ted is a colleague. He trained me as a facilitator for the Institute. So yeah, he's a pretty dynamic individual. And I noticed that he spoke at the Flash conference, which I wasn't able to attend, unfortunately. But yeah, so hopefully that's got everybody's attention here, that Flash is huge. So Dr. Manfield, not everybody listening to this is trained in Flash. Now, I don't speak about it during basic consultation for the Institute, obviously, but all of my certification consultees are required to learn Flash.
Right.
It's just, and all of my colleagues are learning or have learned Flash in my office. It's something you just can't do without. But not everyone knows about this. Could you give like a 1-minute rundown on what Flash is? Yeah.
Well, it's if a person's familiar with the concept of titration, in the old days when we had an overwhelming memory that the client couldn't process with EMDR because they were overwhelmed when they would think of it, we'd water down the memory. We'd titrate it so that it wasn't as intense, and then we would process it in this less intense form, and hopefully that processing would make the memory itself more palatable, and then we could process the original memory. And so I had there are a lot of versions of titration. I had a preferred version that was developed by Christina Kanowski in Victoria, Canada. And I was going to present that at a conference, an EMDRIA conference, and I started wondering, if you're going to water down the memory, how far can you water it down and still get a meaningful result? And so I started experimenting with watering down the disturbance more and more. And it turned out that if you really watered it down a lot, that the memory actually processed more effectively. And we've since learned from MRI studies other researchers have done, that actually the part of the brain that processes trauma is it basically, which it's for people who know about the brain, it's the prefrontal cortex. It becomes relatively inactive when the brain goes into a kind of a fight or flight mentality state. And so what seems to be happening, if we do a processing session in which we water down the target, the memory so far that there isn't any disturbance that the client is experiencing while they're processing, it turns out that the prefrontal cortex becomes more active and we get better processing effects. And so that really is what Flash is. We distract the client so that the amygdala doesn't go into fight or flight, and then we get sometimes just magical, miraculous processing. And so that's basically it. And started out, we just did it for overwhelming memories, but now basically I use it for any memory that I start processing that's disturbing, because it works for everything, and it works more efficiently than EMDR alone or other kinds of processing. It would be a wonderful hybrid to work with exposure or CBT, or and as it is a wonderful hybrid for working with EMDR, because it just takes the initial disturbance away, and one can then decide to continue with EMDR and remove the disturbance completely, or switch over to whatever trauma processing technique a person's used to using.
I mean, I think I would love to. I have a very small training in prolonged exposure, not the like $3,000 one that you get at Harvard, but I would love to, with one client. I just have trouble picking the one because I'm such an EMDR guy, to use Flash with prolonged exposure just to see. Do you know of anybody who's used Flash with prolonged exposure? There's so many people out there treating veterans with prolonged exposure, and the dropout rate for prolonged exposure is already 50%. And what
Yeah,
I've
for
noticed,
the veterans, it seems to be 75%. And then for the therapists, the average length of time that they continue to use prolonged exposure for the Veterans Administration is 1 year. And after 1 year, they just can't handle it anymore. So it's just kind of it's really sad. It's a kind of a torture that doesn't get the results it's supposed to get.
Yeah, it reminds me of, I was first trained in TFCBT when I was like out of grad school and had absolutely no idea what I was doing. And I used it with a foster girl, and I just shut that down within minutes. I thought this is horrific, but I just wonder about, it's, I think it's fascinating. You use the phrase "can't handle it," right? And I'm kind of an Ad de Jong like disciple. He's sort of a personal hero, being an iconoclast, and that's the negative cognition that he uses for his EMDR 2.0 is I can't handle it. Or at least, and so Flash is you can handle it. And that's what I was wondering about prolonged exposure. So you're not sure if anyone is using Flash with prolonged exposure or CPT?
I haven't seen any studies. It seems like a totally unnatural, but Flash has mostly been confined to the EMDR world. And, we've been doing workshops now for PESI, teaching people Flash, and they pay next to nothing. So we basically lose money when we do it for
Mhm.
PESI, but we do it because 75% of the people who take our trainings through PESI
Mhm.
are not EMDR trained. And so we're getting exposure people and we're getting CBT people. And so I'm hoping that it will gradually get some momentum going, and then people will want to study it and do research.
Mhm. Well, I hope that through this podcast, the same thing will happen. That's the whole intention behind this podcast is um, I believe, know my mentor, Jesse Rappaport, who trained me up all the way through, he's the one who recommended me to be a facilitator at the Institute. And he said, "Hey, have you heard about this new thing, Flash?" And I took one of the first trainings, and
Mm.
I just thought, not everybody has a Jesse to say
Yeah,
things like that. So I thought, well, you got 20 minutes, an hour for a podcast. So, hey, maybe they can hear about Flash that way. And
yeah. But I have to say, we've been really fortunate in that when we do a presentation of Flash, we can do a practicum experience where people,
Mhm.
in 15 minutes, everybody in the room experiences Flash. And that can be, we've done it twice now with 500 people at a time. And they get more than 50% reduction in their disturbance from this really brief thing. I can't really do it in a brief podcast. And we're doing an hour and a half presentation for a PESI symposium in September, and in August we're doing an hour and a half for EMDRIA for
Mhm.
their conference. But it's unfortunate that I think for when we do it for EMDRIA, we'll do a practicum
Mhm.
because once people experience it, they're sold.
Yep,
And
that's my experience.
yeah. And so, I mean, that's what happened with me with the EMDR.
Mhm.
I'd had a rear end collision and was basically having mild PTSD. I would get very upset when a car would come up behind me, and I'd be looking in the rear view mirror. And I'd been in a year and a half of Jungian analysis to address it. And then in 35 minutes in the EMDR training, it got resolved by
Mhm.
someone who'd never done EMDR before. So,
Yeah,
that tends to sell a person.
yeah, that's funny. I had the same journey. I wanted to be an analyst, and EMDR became my um, kind of my thing. I suppose that if someone is doing prolonged exposure, they might have a better understanding of Flash. I believe there's some theory that Flash is somewhat, it could be conceived as a subliminal exposure therapy. That
Yeah,
you used to use that metaphor of the card catalog gets pulled out so fast and the memory gets pulled out so fast that there's no activation consciously, and it does the same thing as I would put it from my background, kind of bring up that orienting response,
yeah,
and but possibly in a more full way.
yeah, I would agree.
I One thing that I should probably mention is your websites. That
Mm.
people should go to flashtechnique.com, right? And that you can also find a list of Flash practitioners, which my colleague, incidentally from Poland as well,
Mm.
um, just got to put her little sticker on there. She just took the
Yeah,
training.
yeah,
She's excited about that. And also emdrvideo.com,
yeah,
where you can
yeah.
see the Flash technique actually done.
That's true. There's two examples of the flash technique, and there's 44 full-length videos in total. Most of them are EMDR sessions,
Mhm.
but uh, I consider that one of my primary accomplishments um, as a EMDR practitioner. I mean, Flash certainly is my biggest contribution. I would say that the Flash the EMDR video website is probably my second, in that when I used to go to live conferences, August will be my first in 4 years. But people would come up to me in the halls and say, I've taken this training and that training, and I'm certified and I've been trained. But where I really learned how to do EMDR was by watching the videos on your website. And I believe it, because they're excellent videos, and a lot of them have subtitles and super titles that explain what's going on. And they're all examples of EMDR done by the book and working. So I haven't seen that anywhere else.
No, certainly not on YouTube.
No.
That's the Institute was actually thinking of directing people to YouTube to show people what not to do, but got kind of wary of even that. So, I could say the same thing. For certification, Jesse sent me straight to emdrvideo.com, and also studied dyadic resourcing on there, which I think people would do well to look into, because I do think that resourcing is the most overlooked section of EMDR. And for adolescent boys, this seems to be just, you can't do this without resourcing. But what I love about those EMDR videos that you have on emdrvideo.com is your style, which is just a schmoozy style that I have that just has worked well for me, where I just, I stopped dressing like Dr. Freud at some point as well, partially out of laziness. And I just started being myself, doing EMDR. And my first question about using Flash with complex trauma specifically, I've been thinking a lot about the concept of attention and complex trauma primarily as an issue of neglect, either active or passive neglect, if you want to think of direct abuse as a crime against the existence of a child as an individual, or just what we usually think of as neglect as the same. The effect of creating parts of the mind as being the outcome of the tragedy, but the true tragedy being that a kid had a story and nobody wanted to listen. So attention being kind of the antidote, like as trauma is a phobia, then curiosity is the answer. And as therapists, we kind of model that attention, that attentiveness. I view resourcing as self-care, but trauma time is not schmoozy. Like trauma time is pretty, that has no place there. And when you introduce that seems to be just like my clients just, when you use that style with EMDR, they're just like surprised. I said, well, if this isn't a good time, what are we doing here? We're just repeating the past. And so with that giant lead in, the biggest thing that changed my use of Flash was when you developed that schmoozy conversation technique. And that's all I use. And it's just remarkably effective. And I wanted to just pick your brain about that with regard to, we're speaking about attention. Do you feel that the schmoozy conversation thing, and I love that term, that you think that also has an effect on the efficacy? I think so.
Let me just throw this in before I forget, but in terms of your introduction, Andrew Leeds' website has lots and lots of resources. And one of his pages is about DID, and he quotes some research that even though people think, they encounter a client who's been molested as a child, and the client's DID, and they think, oh, they're DID because they've been molested at such a young age. And there's research now that basically DID tends to come from neglect. It's not the molestation, but you encounter a client who's been molested, and how do people get molested, especially when it's an ongoing situation? You have to have parents who just are not noticing, are not looking. And so invariably there's severe neglect there. And to me, neglect is, when you think of an infant, my resourcing book has a image on the front of this little baby looking into the eyes of his mom, and there's this really caring gaze in both directions, and I think of that as just essential for an infant to have a sense that they belong in this world, and that they are useful and valuable, and that they're lovable, that they deserve love. And neglect is the opposite. You have a situation with neglect, that infant just doesn't get that validation that you really have a place in this world. Your life is really important. And so just to underscore what you were saying about neglect.
I can't add anything to that. I really can't. Thank you for saying that. I just I just wonder if that conversational, positive, engaging focus, for those, if you don't know that term, like, go to emdrvideo.com and take the Flash training and all that. But that use of, like, as you said, the distraction while that subliminal exposure is brought up, having that conversation, that's attention. That's attention. What if do you think that has a different effect, especially with complex trauma?
Well, it's for a long time people were trying to figure out what makes EMDR work, and I eventually just, after reading a lot of different theories about why it works, I eventually just came to the conclusion that there are a lot of things about EMDR that make it work. And so I don't try to single out a particular thing. And I think that's true with Flash. I think the attention, that intense connection helps. But, our theoretical model comes from FMRI studies done by Paul Siegel. And his studies clearly showed that he did it with arachnophobes, people who were afraid of spiders, and the people who saw images on the screen of the spiders, the amygdala got activated, they felt afraid, and on the fMRIs you could see the prefrontal cortex closing down. And for people who didn't know they'd seen a spider because it was flashed so quickly, they didn't have that reaction in the amygdala. The amygdala still got activated, but there was no conscious fight or flight response. People didn't know they'd seen a spider, and the prefrontal cortex became very active in processing those images of the spiders. And then those people who had no idea they'd even had any kind of exposure to spiders they had more significant improvement in their arachnophobia than the ones who knew they'd seen a spider. And that change in their phobia was still evident a year later at follow-up.
Yeah. And I think about Professor Vanderhart's The Haunted Self. The definition of trauma is a set of phobias, and we're treating phobias. And I also think if it seems like the most encouraging thing for an EMDR client or a Flash client or a both client, as many of mine are, is that first memory that gets conquered is like the best resource. And I'll say something like, a memory is a memory is a memory. If we can do it to that one, well, we can do it to the rest of them. And it's like the activation just automatically, it's like, you know.
When I teach EMDR, I teach something that I don't think any of the other trainings do unless they have incorporated. I'm constantly hearing that
I'll let
other
you know.
Trainings have pulled in my concepts, but I talk about something called low-hanging fruit.
Yeah.
Once you do a history and you have a whole list of people's trauma memories, you can usually find a memory that is either a single incident trauma, it's just something that happened, it doesn't relate to any other trauma, or it's the first in a cluster of traumas, so that it's not being fed by other trauma experiences. And I teach people in the trainings to do low-hanging fruit first. One processing session of low-hanging fruit that can get resolved in a single session, because most people have never had the experience of having a trauma memory just resolve, where they can focus on the memory, on the trauma, and then 20 minutes later, it's just not disturbing anymore. And that's mind-blowing for people. And once they've, like you say, once they've had the experience once, then they can buy the idea that, gee, I can do this with all my other trauma memories, and it's going to work.
Right. I hope you enjoyed this episode. Whatever your opinion of the Flash technique, either as presented here, as used personally, or as researched elsewhere, we must admit that it works and it's healing a lot of people. However, future guests will offer counterpoints, especially related to the use of Flash with attachment trauma and with respect to the role of attention and narrative in healing the theft of meaning in complex trauma, especially that occurring in childhood. In the next segment, a future episode of the Dissociative Table, Dr. Manfield will be discussing the power of single session relief for buy-in to trauma therapy with Flash. Also discussing the relationship of Flash and the theory of structural dissociation of the personality, things which at first glance seem very much in opposition. We speak about limitations of Flash, possible repairs, and the power of laughter in trauma therapy, including working with traumatized parts of self even. He speaks about reducing complexity in the treatment of complex trauma, including pre-verbal trauma and severe memory loss, working backward rather than forward. Again, thank you for listening, and we'll see you next time at the Dissociative Table.